I remember when I sent the first large group of patients in an article, and the first response that I get from a journal was as reduced to two lines. The lines were saying, "I don't believe on ultrasound. The only thing I believe is what I see with my own eyes." And if you look the vascularity, you can have a lot of information about the lesion because you can discriminate. For example, if you are looking an inflammatory disease, you can say this is active or non-active. Or if you are looking a tumor, for example, you have a different pattern of distribution of the vessels compared to, let's say, benign versus malignant. Or if you are looking a vascular lesion, you can discriminate different types of vascular lesion according to the blood flow that you are looking in the screen. So there are many points that the color Doppler and all these microvascular imaging softwares can give us, and I think this is a really valuable information.
Hello, everyone, and welcome back to another episode of the HairStacks podcast. Today, we have a very special interview. We're going to be looking at imaging technologies when it comes to the scalp and other sort of dermatological pathologies. And I'm here with a very special guest, and I will ask them to introduce themselves.
Hello, everyone. I'm Dr. Ximena Wortsman. I'm a radiologist, and I work in dermatological ultrasound for the last 24 years. In different applications, developing patterns for diagnosing entities, scorings, and ways of monitoring and imaging dermatologic conditions. We work in tumors, benign, malignant, in vascular lesions, and of course, scalp conditions, studying hair diseases, also in nail pathologies, and in aesthetic problems. So that would be most of the areas. Of course, there are some developing fields in dermatological ultrasound, but I would say that is the summary of what I do in my practice. So thank you for inviting me.
Thank you for coming on. So, I guess my first question is, can you tell us about your educational background and what led you to specialize in, I guess, this field of like radiology and dermatology? How did you come about this sort of intersection?
Okay, when I ended my residency in radiology, I wanted to, study more and do something interesting. So I decided to train in musculoskeletal ultrasound. And for that, I went to Henry Ford Hospital in Detroit. And when I was there, the first high frequency probes were developed. So we got a machine, and everybody was trying this machine and the device in the tendons, in the thyroid, and I tried on my own nail. So I found that the images were so great. I have never seen a nail before in imaging. So I went to the library on top of the on the building, and I looked if this was published, and I found a couple of articles, one from a couple of Danish authors, and the other one from some Italian authors that were performing a very basic type of ultrasound device, but still you can see the nail. So I wrote them, and to make the story short, I made a project to put the same machine that we had in Henry Ford Hospital in a department of dermatology in Copenhagen. So I went there and I scanned dermatologic patients with this machine. and I really was excited because I realized that I saw a lot of things that I thought they were important. With the Danish authors, we published the first article about dermatological ultrasound using a variable frequency probe. These probes are different from the old probes because you can adjust the frequency, and that allows you to adjust the depth of the penetration. So you can observe, for example, a skin tumor from the epidermis to the deepest point. So in contrast with other imaging modalities, like, for example, confocal microscopy or OCT, we don't have a limitation, an important limitation in the penetration. That makes ultrasound a very interesting and useful modality in dermatology. So that's how I started.
Wow, thank you. That was really interesting. I didn't really know that there was a tool like that where you had the adjustments. Um,
Mhm.
so I guess moving on from there, could you give a brief overview on how I guess ultrasound technology works? You touched on how different frequencies can get into different depths because usually when people see like the ultrasound imaging itself, I guess if you're not trained, you have a very hard time in trying to understand what you're actually looking at because most people just see it as black and white images. I guess how does a technician or a physician make sense of the structures they see from those images?
Well, every imaging techniques needs training, as anything in medicine. But an ultrasound, I believe, with the new devices, it is not difficult to discriminate the skin layers. In fact, for example, ultra high frequency probes that can go up to 70 megahertz, they present an axial spatial resolution up to 30 microns. So it's like to look the lower magnification of histology. You can see very cool details, like, for example, the hair follicle, the sebaceous glands, the erector pili muscle, and they're very similar on imaging as an histology. So it needs training, but of course, if you compare with histology, it's very similar. I hope
Most
I answered your question.
Oh no, you definitely did. Yeah. In my I guess research and while I was reading your papers, I became acquainted with the hypoechoic and hyperechoic and anechoic terms and
Mhm.
it was very interesting because when you actually pay attention to the images, I think it was in the paper dealing with sonography and scalp pathologies, you can actually
Mhm.
see the differences in the tubular structures that of a normal hair follicle versus one that is inflamed, and trying to get an understanding on how I guess inflamed structures tend to, how they
Yeah.
tend to appear, right? And also how fibrotic structures, depending on how extreme the fibrosis is, it has a mixture of hypoechoic and hyperechoic kind of, I guess structures to them. So it's very interesting. I guess for me, and maybe I'm skipping a bit too quickly in the questions. I
Mhm.
I'm kind of I don't understand why this stuff isn't used as often in like the clinical setting, and maybe you can give your insights to that because there are some conditions where people don't want to do things like scalp biopsies, for example, right?
Mhm.
Um, but I still think like having a an understanding that there is some sort of inflammation and where that inflammation is occurring would also be important to the physician along with the patient in getting proper diagnosis and therefore maybe a proper treatment. I guess I want to know your perspective as to uh, whether or not this is a common sort of thing to use ultrasonography in the clinical setting when examining a patient, or is it a very niche kind of application?
Yeah, no, to give you an idea, I work um, the whole day performing dermatologic ultrasound examinations. Um, I would say that the, the ultrasound examination, at least in several uh, points of the world, is now under a clinical real world. And there are a lot of countries that already have trained operators on these examinations. Of course, I think it's underused in the US, for example, um, probably because I think the radiologists are not the ones in charge of the examinations, and that is a thing that is make it difficult to develop imaging techniques. Huh? Um, on the other hand, I think we need to make a better diffusion of this imaging technique, at least in some countries. Huh? But there are many points of the world where ultrasound is under the clinical setting at the bedside. For example, in Chile, in Argentina, in Brazil, in Colombia, we have also in Spain, in Italy, in Romania, in Australia, many countries around the world. And for example, in the last consensus that we did for hidradenitis suppurativa, which is a hair follicle disease that affects young people, which is a very devastating disease. We just published a consensus, and the consensus what was published in the Journal of the European Academy of Dermatology and included in a Delphi study 24 experts from 14 countries and 4 continents. So this is expanding, and as you can see, if you look and if you simply put the words ultrasound in dermatology in PubMed, you will find that there is an explosive growth of the publications, much higher compared to confocal microscopy and OCT. That's a simple exercise. And so I think it needs diffusion probably, and also training, education of the physicians and all the operators that will perform this examination.
Thank you. That was a very interesting response. And I guess my question was mostly coming from a US sort of centric kind of position. And to be quite honest, most of the papers that I've seen on this particular topic that involves ultrasonography and dermatology, or really any other imaging technique and dermatology, mostly comes outside of the United States of America. So there's that. But on that point, I read another paper, a very interesting paper from some Chinese researchers, where they actually cited your work. So it seems you've been really influential and you've really paved the way for advancing dermatological imaging techniques. Now, this paper that I'm talking about is titled, quote, Diagnosis and Differential Diagnosis of Tertiary Androgenetic Alopecia with Severe Alopecia Areata based on high-resolution MRI, unquote, published in 2023 by Yong Gang Li et al. In Skin Research and Technology. That's the journal. And in this particular paper, you see some super high quality images, just structures of the hair follicle in different pathologies. It's amazing, right? You can see how the hair follicle and scalp looks like an androgenetic alopecia against a healthy control against alopecia areata. But when reading this paper and looking at the images, it made me think, what could we do with more advanced imaging? So I guess I have this question, right? As imaging technologies like high-frequency ultrasound and HRMRI advance, they not only enhance research into specific pathologies, but also improve patient experiences, potentially eliminating the need for biopsies, not, wholly, but partially. This progress leads us to utilizing big data from electronic medical records, including imaging data like X-ray images and MRIs. Like, for instance, in 2019, the Massachusetts Institute of Technology, or MIT, collaborated with a local hospital to develop software that predicts breast cancer from scans. And given this kind of innovation, are we still decades away from widespread clinical use of this kind of technology, or can we expect such sensitive imaging detection tools to become more common, say, within the next 5 to 10 years?
I think the reality will vary from country to country. Uh, Probably there will be some dermatologists that will have their machines in their offices. For example, if they are dedicated to aesthetics and they want to roll out very quickly a complication, for example. Uh, some problem, some examinations will be to radiologists. So I think it will be a mix of operators, not just one, probably several, depending on the specific field of dermatological ultrasound. Um, uh, but I think in the future, we will see more and more new developments, such as, for example, artificial intelligence in dermatological ultrasound. We have now some publishes articles, but also there is an ongoing work on that. Still, I think it needs a lot of effort because, as you know, artificial intelligence is not automatically intelligent. It needs a human input, and we need to, let's say, insert the correct information in the algorithm.
Correct.
Otherwise, it's very difficult to have a reliable data. So I think it's gonna go that way. Another point of development is the new ultra high frequency devices we have in the research field now. Some machines that work with, for example, 300 or 500 megahertz. They are still not on the market, but they are really the same as histology. If you look the images, they are very, very similar. So I think in the future, probably we will have some kind of radio pathologies or something like that, because probably biopsies will not be necessary anymore, because we will look into the skin in a non-invasive form. Um, Another point of development is the elastography. For example, elastography is a software that can measure the stiffness of the skin, and it could be useful in some fibrotic disease, such as, for example, morphia. So probably in the future, this software will improve, and we will have a better support of these diagnoses. So there are many, many things that are going on.
Yeah, that sounds really, really exciting. And I guess to that point, have you seen any? I'm not sure what you can speak on, but have you seen any like biotech companies or pharmaceutical companies in the dermatological field make use of this sort of ultrasonography when it comes to certain dermatological conditions? So, for example, right, I recently talked to a biotech pharmaceutical company in China and some of their representatives. This company is called Kintor Pharmaceuticals. And they said one of their lead scientists talked about how they wanted to do biopsies, but I guess they didn't get the chance to do so because there wasn't the investigators in the clinical trial didn't deem that appropriate. Along with some of the patients, they weren't too keen. Again, having someone just cut out a chunk of their scalp and examine it. Um, but do you see it's this sort of imaging technique it being factored in methodologies for these, I guess, future clinical trials for new treatments when it comes to examining, let's say, something like the follicle?
I think, of course, it can add information to the puzzle of the diagnosis that the pathologists cannot see. One of the advantages of ultrasound is that you can scan several regions of the patient. And that is an important difference with the pathologies, that they receive just one small sample or very small samples of the tissue. We can we can have a very wide vision of what is going on. For example, if one disease is the same in all the points, if, for example, we have some areas of activity of an inflammatory disease and areas of inactivity in the same corporal region. So there are many points that where imaging can add information that histology cannot. And I'm not saying that histology is not good. I'm not saying that. I'm saying that imaging gives you another perspective.
Yeah, I would certainly agree with you on that.
Mhm,
And the I guess the advantage is, as what you said, right? Like you get to have more insights, right? And it's never a bad thing to have more data on hand. Um,
mhm,
as opposed to, I mean, again, with a biopsy, you're mostly, kind of stuck with that one area that you're checking. And, there's limitations. After you biopsy that area, you're going to get, some sort of scarring that forms. The patient might not like that, even if they already have fibrosis in the area. But with this sort of, I guess, non-invasive imaging technology, where it's, I guess, reaching the point where it's pretty much has the same histological features to what you would see in a typical biopsy report in terms of its structures, right? Not necessarily the things like maybe potential lymphocytic infiltrate, or seeing certain like I guess white blood cells doing certain things in the tissue, but you're able to see the
mhm,
structures and their sort of, I guess, changes. Um,
mhm,
that's it's pretty cool because you have a sort of reusability that doesn't really harm the I guess the integrity of the patient's skin, right? Long
mhm,
term. And also there's this one company called Amplifica. I was thinking about this because they made some really bold claims about a new treatment. It's called AMP 303. It's to treat androgenetic alopecia and potentially other alopecias, where they said in their study after one injection of their it's an osteopontin derivative glycoprotein. After one injection, they noticed in the area of injection increase in like hair counts and transition from vellus hairs into non-vellus hairs. And I thought to myself, well, if they couldn't get a biopsy, what better way of proving maybe some sort of structural change to the follicles by using some kind of imaging technique? Whether it's ultrasound, high frequency ultrasound, or you know HR MRI. I thought that would be pretty novel in the sort of clinical trial space.
Regarding the high resolution MRI, I think it's not in the market. That is something in research. It is not available I mean, for us. Sometimes there are technologies that are only on papers, but are not really in the real world. We hope that in the future we can have it, and compare all these technologies under real world settings, because that is the way to know if it's an imaging technique can add useful information. I believe that an imaging technique is useful when it has the potential to change the management of a patient. If the imaging technology doesn't have this power, it stays out of the market because it is not possible to develop that.
Yeah, yeah, that's true. That's a good point. And I guess there's also a degree of accessibility there as well. I can only
Mhm,
imagine how expensive it would be to use something like an, high resolution MRI just to check a
mhm,
patient. So there's definitely some sort of, I guess, cost prohibitive kind of I guess wall over there. Um,
Mhm.
so wow, I guess we burnt through a lot of questions. That was pretty fast. Um, I guess, are there any specific conditions where you would find using ultrasound imaging to be particularly necessary or more preferred than just, you know, resorting to a biopsy? Like, can you think of any sort of like preferential, I guess, protocols? Because in the United States, like you said, and like I've done research on, this sort of, ultrasound imaging doesn't seem to be that common, right? But I would imagine other countries where it is common, maybe for certain conditions, they would rather use that ultrasound imaging rather than just like cutting into the tissue. So maybe, I guess, something like HS, for example.
Mhm. Well, HS is a common indication because it is impossible to know the reality of the disease if you don't use ultrasound. MRI doesn't show the axial spatial resolution of ultrasound in the current versions, of course. Um, but there are several areas, I would say, for example, aesthetic problems. Even in the scalp, for example, to perform a hair transplant, you need to have an idea what is going on and to know if there are remaining hair follicles. If, for example, the patient has enough fat for inserting the follicles. This is important information for the person who will do the transplant, especially in patients with scarring. Um, but I work in the 360 degrees of dermatology, so I would say that they're relevant information in all the fields. If you look, for example, skin cancer that also occurs in the scalp, it's important to know the depth of the tumor, and that is information that we cannot get from the visual inspection or with dermoscopy or confocal microscopy, because if the tumor it goes beyond the 300 microns, we don't see anything with a confocal, and the same with OCT. If the tumor goes beyond the 1.5 millimeters, we don't see anything. And in contrast, on ultrasound, we can detect the involvement of the musculoponeurotic layer, the involvement of the bony margin, the involvement of in the face, for example, of the cartilage, then the muscles. So it is very important information if you want to perform a surgery. Uh, Another important information is like it's a geographical information, because sometimes you have an important artery beside your incision zone, so it's important to not harm this vascular structure. um, I think skin cancer is a very good indication. Still, I think it's underestimated for the use of ultrasound. And of course, benign tumors in vascular lesions, anomalies, we can differentiate, for example, an hemangioma from a vascular malformation. And that is very different because we can have different types of management. In an hemangioma, we can give, for example, propranolol in an infantile hemangioma, and in a vascular malformation, depending on the type, we will indicate a laser or an sclerotherapy or maybe a surgery. So it's changed the management. In nails problems, it is also an indication because we can, for example, support the diagnosis of nail psoriasis and lichen planus. That is very difficult to say from the clinical point of view. There are cases that could be challenging. So there are many practical examples of the use of ultrasound in dermatology, both in the scalp and the rest of the body.
Wow, that was a really good explanation, and it makes sense, especially when you were talking about, I guess, the sort of limitations, right, when it comes to, I guess, tumors and their depths, and how you can only you're essentially limited by your devices or the capability of your devices, right? Like,
Exactly.
and I think that's an important aspect, even when it comes to just regular biopsies, so to speak, right? If you're not cutting it at a certain depth, I mean, realistically, the tumor could still go below, I guess the typical, what, 4 millimeters of depth that a biopsy would comprise of. Um,
Mhm.
so I guess really, um, my thinking of them on the matter is that, so we already have these technologies like the ultrasound, high frequency ultrasound, imaging technologies that already exist. But I think, at least in the United States, it's more so the application of it, right? How how do you how do you convince physicians to to buy into that and actually use it in their practice? Do you have any like colleagues you've talked to before about this particular matter? I'm mhm.
There are centers in the US that are using dermatological ultrasound, for example, for certain applications. In the international consensus that I mentioned before about HS, there is a center in Henry Ford Hospital. They are using ultrasound for scanning the HS patients. And that is real world, is their daily practice. So I think it's going to start with some focal applications in different centers because the reality is different from state to state, and probably the needs will be different. For example, the setting of a public hospital is different from a private hospital. The setting of a children's hospital is different from an adult hospital. So it will vary probably depending on the points of developing of the different institutions and the settings of the same institution, what they usually see, and of course the interest of the physicians to develop this area, because everything at the end is personal.
Most definitely, most definitely. I guess moving on to, I mentioned this earlier. When it comes to the features of scarring and non-scarring or non-fibrotic tissue, what are some features of tissue that is fibrotic and tissue that isn't fibrotic? If you can kind of walk the audience through it a bit.
Well, on ultrasound, you can see the fibrotic areas because they are, let's say, gray or hypoechoic, and they have a laminar pattern, which correspond to the fibrotic pattern. So that is different from a non-scarring alopecia, which doesn't have that pattern. So there are some differences in the way they appear in the screen.
Most definitely. I think another aspect that I forgot to touch on is the use of color Doppler technology and
Mhm.
its use case in detecting blood flow, right? Now, how with these devices, do they come in as an like? Do you have to do you have to switch between different devices where one has a capability to you know use a specific depth and the other one maybe has a capability of being solely for color Doppler imaging, or do these devices usually come in as an all-in-one kind of bundle?
Um, well, first of all, for practicing dermatological ultrasound, there are some requirements. The first is to have a color Doppler ultrasound machine, which means the machine that comes with this software, of course. The second is to have a probe, which is this device that connects, the skin with the machine, working in frequencies equal or higher than 15 megahertz. Uh, and the third is, of course, a train operator. You got the three things you can start, let's say. But if you go to the market, there are multiple devices. So this is like buying, let's say, a music equipment, or a computer. You have different types of computer with different specifications. One of them are more simple, the others are more specific, more sophisticated, high end, more expensive. The other ones are more basic. So the selection of your machine probably will depend on the type of practice that you have and the budget, because there are significant differences between all of the machines. So, for example, for the scalp, I would recommend at least a notebook type of machine, or a big machine, because if you use two simple machines, probably they will not be able to detect well the hair follicles.
Yeah, that makes sense. The sensitivity of the device is very important, because I mean, with those follicles are really, really small, and at
Oh,
least
yeah.
when you're trying to make, I guess, and I would only imagine when it comes to the hair that those follicles produce, right? Those vellus hairs as well. I would imagine you really need some sensitive equipment in order to kind of detect those features, right? So it has, I guess, this sort of running theme is that you're limited by I guess, the scope of your device, so to speak. Um,
One thing that I would like to say is that
mhm.
color Doppler is a software that allows us to detect vascularity. For those of you that are not familiar with ultrasound, it is important to explain that. That is cool because you don't have to inject contrast media. You just need to look into the screen and look the blood flow in real time. Now we have more softwares on vascularity, such as, for example, microvascular imaging, and that softwares are even more sensitive. So we have the option to look the vascularity without having to inject contrast media and without the risk of having an adverse reaction. That is very important. And if you look the vascularity, you can have a lot of information about a lesion because you can discriminate, for example, if you are looking an inflammatory disease, you can say this is active or non-active. Or if you are looking at tumor, for example, you have a different pattern of distribution of the vessels compared to, let's say, benign versus malignant. Or if you are looking a vascular lesion, you can discriminate different types of vascular lesion according to the blood flow that you are looking in the screen. So there are many points that the color Doppler and all these microvascular imaging softwares can give us, and I think this is a really valuable information.
I would certainly agree with you on that. Yeah, just seeing how vascular, a particular or vascularized a particular structure is, especially with something like a tumor. There's a lot of utility for that. And I also find that, you know, this imaging, these imaging techniques provide a sort of real time monitoring of of those sort of conditions, right? Where you can possibly convey to the patient, what's going on, right? As opposed to, again, when you do a biopsy, you have to send that to a lab. The lab has to make certain assessments. And although, there are, again, some things that are very unique to a biopsy, right? You can see what specific cells, what they're doing. I guess the immediacy of just understanding that, okay, we know that, there's this sort of structure. We know that it has this sort of, vascular network. We can possibly make some conclusions on what's going on there. That, I guess, in my opinion, uh, provide some sort of a sort of immediate assurance that you know the physician has an idea of what's going on, right? As opposed to just like saying, okay, just wait for the biopsy report to come back in 3 weeks or something like that. So I find ultrasonography to be very important there, where it's like you're giving an answer, sometimes within the same
Mhm.
day.
Mhm. Exactly. We can make a follow up on that patient. And since it's a safe imaging technique, because it is not a radiating technique, we can make a follow up on the patient when we want. And we don't have a real limitation about that. You can see the follow ups of the pregnancy, it is well known. We can study the patients when we want. So that is the real advantage of ultrasound. And tell me, what disease are the most worrisome for your audience? What do people ask you?
Yeah, so people in my audience, because we're mostly like we focus a lot on like hair loss disorders, they're concerned when it comes to inflammatory scalp conditions, right? Particularly scarring alopecias. You mentioned
Mhm,
previously lichen planus. Well, there's lichen planipilaris, derivative of lichen planus, affecting
mhm,
hair follicles, right?
mhm,
And there are some people who, despite being told they have androgenetic alopecia, they are on some pretty serious drugs, 5-alpha reductase inhibitors like dutasteride, which
mhm,
depending on the dose you take between 0.5 milligram up to 2.5 milligram eliminates scalp DHT. DHT, being the cause of this sort of hair loss condition, eliminates scalp DHT by 50 to 80%. So with somebody that's still losing hair in that sort of condition, there is a need for further investigation. And there have been people in my audience who, upon getting a scalp biopsy, they realize, well, they had a multitude of different alopecias, right? Sometimes even
mhm,
three at the same time. Where the aside from androgenetic alopecia, the other alopecia, I guess, agitators in this instance were inflammatory and perhaps autoimmune, right? And in the literature, at least from what I've seen, there isn't, the reliability of the rates of different alopecias. There's this sort of bias that exists that I haven't been able to find a good, explanation for. For example, there was this paper by I think the researcher's name is Joshi P. Tejas, and it was concerning the instances of different alopecia conditions. And they concluded that lichen planipilaris, out of a database of around 324,000 patients, that lichen planipilaris only occurred in 142 people. But I think what is essential to take note here is that when you read the paper, there is no mention of all of the subjects in the study, in this particular database, being biopsy confirmed for their alopecias. Because it's very well possible that a single person can be dealing with multiple alopecia conditions, not just androgenetic alopecia, not just lichen planipilaris or fibrosing alopecia in a distributed pattern of some kind. And in fact, there are other papers that kind of highlight this being the case, and it actually contradicts what the literature, or that particular literature by Josh P. et al., was showing. So, if I am to recall correctly, and I have to use my memory here, but there was a paper, I think it was titled, like, quote, frequency of the types of alopecia at 22 specialist hair clinics, a multi-center study, something like that, by Sergio Vanyo Galvin et al. And forgive me, I'm really working on my memory here, but in this paper, there were 2,800 patients. Around 70% were female, and I think 30% or so males, so some mix of those two ratios. But with only 2,835 patients, there were 3,133 diagnoses of alopecia. So some people had multiple alopecia conditions, right? So this flies into the face of that specific study done by Josh A. et al. And that study, by the way, was conducted by the Mayo Clinic. And the Mayo Clinic has another weird study that they conducted as well. And in that particular study, they started with the premise that lichen planipilaris was a uniquely postmenopausal, or I guess even premenopausal, female condition, alopecia condition, right? When in reality, that really isn't the case. And I don't think there's any sort of justification because it is implied that within that particular study, they had some data points for males, yet they kind of excluded it because they were working on the idea that they wanted to more accurately capture the hormonal realities of lichen planopilaris, right? And this study is titled, quote, I think Lichen planopilaris in women, a retrospective review of 232 women seen at Mayo Clinic from 1992 to 2016, unquote, by Sidney C. Larkin et al., and it was published in 2020. And here the researchers, again, they were making claims that we had to exclude males from this study so we can, more accurately determine what is influencing lichen planopilaris. And I think the case here kind of shows how biased the literature is. The literature wants to, or at least how current practice is, physicians tend to biopsy women more than men, right? And this sort of practice aligns with the findings in the study titled, quote, Evaluation and Treatment of Male and Female Pattern Hair Loss by Olson et al., 2005. And it actually states that, quote, diagnosis in men usually does not require a biopsy unless atypical patterns such as diffuse or female pattern hair loss or scalp changes indicative of cicatricial alopecia complicate the case. In women, however, biopsies are more commonly performed to exclude chronic telogen effluvium, diffuse alopecia areata, or early cicatricial alopecias. And that's the end of the quote. And you can kind of see how this practice kind of permeates till this day. And in fact, if you turn your attention to one of the leaders in, cicatricial alopecia treatment, being Dr. Jeff Donovan, he says in one of his online documents, and I have it pulled up over here. Give me one second. He says, quote, one needs to take into account the patient's entire story. If a physician just biopsies every patient that comes into the office, I can guarantee one will make a whole lot more diagnoses of LPP than truly are present. I'm a big believer in this, even though LPP is underdiagnosed in the world. But by listening to the patient's entire story and examining the scalp and reviewing what the biopsy shows, not just the final readout on the bottom line, one can usually get a fairly good sense. However, in rare cases, time is the best judge, as a missed case of LPP will likely declare itself over time, unquote. So with all that, being into account, we also have to consider the fact that some of these, cicatricial alopecia cases can kind of mimic androgenetic alopecia norward pattern or, diffuse patterns, right? If we look at a particular paper titled, quote, Lichen planopilaris in the androgenetic alopecia area, a pitfall for hair transplantation, unquote. And this mentions how lichen planopilaris can overlap and mimic even seborrheic dermatitis. We also have another article titled, quote, Lichen planopilaris mimicking androgenetic alopecia, the importance of using a dermatoscope, unquote. And this shows exactly as the title implies, right? Lichen planopilaris can mimic androgenetic alopecia. And the same findings were actually mirrored by Dr. Ralph Trueb and Martin Zinkernagel in their paper titled, quote, Fibrosing alopecia in a pattern distribution, pattern lichen planopilaris, or androgenetic alopecia with a lichenoid tissue reaction pattern, unquote. So there's a degree, an extent of kind of uneasiness in the space, right? People are stressed out. They just want better diagnostic tools. They want to better understand what is the alopecia they're dealing with. And that's what my audience is interested in. But I think all of this just goes back to what I was saying earlier, how, this kind of just prompts us to have, or for a need to implement better screening tools, not just in the, initial physician assessment, right? But also in clinical trials as well, to kind of get a better understanding if a treatment is actually working. And honestly, that's why I think for many dermatological clinical trials, right, maybe ultrasound or high frequency ultrasound imaging could be used. Like it has to be used. It has a space, but I think it's barely, if not at all, being used for clinical trials and assessing, if particular treatments are efficacious.
There is a strong need to add imaging, I would say ultrasound, into the clinical trials of drugs. Because so far we see that most of the clinical trials don't include imaging at all. And I think that it's a problem because they don't have the full information. I think the companies could save millions knowing the reality because what we see, for example, in HS, we see that, for example, there are failures of treatment. There are people who don't respond to the biological drugs, but what is happening is that the severity is underestimated. We see that on ultrasound. So I always think that there is a strong need for include imaging in the clinical trials. Maybe at the beginning, not in the whole trial, but at least make an arm. Make an arm and look some group with imaging. That conclusion was also part of the consensus that I mentioned because where everybody was thinking the same.
I have to agree with you completely. It's and that was, I guess, the point I was trying to bring up earlier. But you put it so eloquently. I don't know why they don't include that, imaging techniques in these clinical trials for dermatological conditions. It would very well save them, millions. Just first, I guess, getting at least maybe in like phase one or whatever, getting some sort of understanding about, the severity of the condition, right? So maybe the drug is only effective if you are, if you're not so severe or if you're on this end of this grading system. Maybe that could be the reality of the situation, right? Um, I just don't know why they don't include it. And that's, at least for me, when it comes to other sort of, drugs that have failed the alopecia reversal, I would be very, interested to see if some of those drugs, had they used, let's say, proper imaging techniques, maybe maybe they transitioned a lot of follicles from, being intelligent to anagen. Maybe, that would have been interesting to note. Where if there was a new sort of methodology, right? Typically, when it comes to hair loss, there's the total area hair count, where within a given area, using imaging like a phototrichogram, where they take a picture within uh, a given area of the scalp, they count the number of hairs that grow in that certain area. Okay, that's whatever. But it would be cool to see the telogen to anagen ratio, right? Or it would be cool to see if there's any sort of increases in, hair follicle, activity or density in a specific region. So I don't know why they don't include that. That's a good point.
Yeah, I think maybe cost is one of the reasons, but I think it's not totally understandable because if you don't have the true information, how can you take decisions? Uh, in HS, for example, the problem is that they select for late disease patients. So when you have a very severe patients, maybe the impact, I mean, is not so terrible. The problem is that when you underestimate the severity of it, stage one and two. So I think probably the stage two is the one that I would submit to these trials. Um, anyway, I think it's we hope that with the force of the publications and the diffusion, the companies could include imaging on their clinical trials. I think it's definitely necessary.
Most definitely. Have you made any sort of proposals to any companies?
Several times, but at the end, when it goes to the top, the decision is not made.
Wow. So, I'm trying to think. What would uh, what would
I don't
make?
know. I think, I
Yeah.
think um, they on one side they feel that maybe they don't have too much operators. I mean, trained operators. They don't want to have an additional cost with the machines. I don't know. I think it's everything could be done if you make a proper training. You have the adequate machines. Everything could be done. But I don't know. I mean, at the end, when it goes to the top, the final decision is negative so far. Huh? So far, maybe in the future they will and they will really give up.
Hopefully it changes because I just don't see why. Like again, you would the amount of information you get from that is invaluable. So and it could even
Mhm.
save them money. Maybe they might find out that their interventions early on aren't as efficacious as they're assuming it to be, and that that would save them a lot of money in just simply
Mhm.
adding a new sort of imaging technique. And that kind of goes back to the thing that I was talking about earlier when it comes to lichen planopilaris.
Mhm.
When I looked at this paper, it said only 42 out of 320,000 people in the database had it. I ask myself, how can we make this assumption? That is a like there are some people that deal with multiple alopecia conditions at once. Was everybody in this database biopsy confirmed? Right? So you run into these sort of issues in the literature where there are just some things for some conditions that aren't really represented, I guess you can say quote unquote properly, and that's mainly due to a limitation of, I guess, of the methods. Maybe they don't have the proper tools in doing so, or maybe for whatever reason the, I guess, procedural process just isn't well defined, and it's even reaching into the sort of clinical trial world as we just kind of brought up.
Mhm. Yeah, it's a discussion. Of course, there are several weaknesses in some of the studies that you can assume, and the problem is was when you deal with research that doesn't fit with the real world. That is the problem.
Very much, very much. I guess,
Mhm.
now we're drawing towards the end of the podcast. We've been at this for about 50 minutes. What are some insights you can give to someone who, I guess, wants to go down this particular path of radiology and dermatology? What's some advice you can give to someone who, is trying to get in this sort of field? Maybe they're right now they're in their undergrad and they're thinking about going to medical school and they're listening to this right now. What's some early career advice you could give to these sort of listeners?
I would say my recommendation is to look for the literature, the published articles, the published books. There are several. Um, and also m- make a correlation of the findings between the clinical, ultrasonographic, and histologic findings. Work as a team between the clinician, the radiologist, and the pathologist. I think that improves definitely the practice. Uh, and of course, be patient to have a learning curve, because nothing is instantaneous. We need to have a learning curve. There are several courses under the umbrella of several scientific societies. For example, now in March there is a course in the American Institute of Ultrasound Medicine about dermatological ultrasound. This course is possible to attend, and this is the Ultrasound Society, the American Ultrasound Society. For example, in the meeting of the European Academy of Dermatology in September in Paris, there's another course of dermatological ultrasound. We have another course in Romania, in Bucharest, in September. There are small courses. I just gave one in Sao Paulo the last weekend. So there are many courses. I have an Instagram and my Twitter. I always post these courses there, and in the skin ultrasound web page. So I think the first is to become an informed person and look for some training and then correlate, correlate, correlate. That would be my suggestion.
Yeah, that's a very very good advice. And also just another question I thought of. What were some of your early career challenges?
There's several because at the beginning, um, for example, for publishing articles, there were no reviewers. So when I send an article to a dermatologic journal, they used to tell me that the article was for a radiology journal. And when I sent the article to the radiology journal, they told me send it to a dermatologic journal. So that was a problem. And then another problem is that you need to be patient because at the beginning the clinicians sometimes they don't understand the protocols why the examinations need a certain protocol. um, for example, if you are looking at inflammatory disease, you cannot look only one point. You need to look more locations. That is also a challenge. Another challenge was that I didn't have anything described in the literature when I started. So I have to go to the pathologist and make a correlation on what we are looking on ultrasound and what we are looking on pathology, so I can make the match of the structure. So there were several challenges. It's a long road. I have been working in the last 24, 24 years in this field. So I have suffered a lot of issues. I remember when I sent the first large group of patients in an article, and the first response that I get from a journal was as reduced to two lines. The lines were saying, "I don't believe on ultrasound. The only thing I believe is what I see with my own eyes." So you can see that there are people that really are very skeptical, mainly the most senior ones. But now a new generation has come, and the new generation is more open to see technology, to see what is going on with imaging in dermatology. Things are changing. We have seen the launch of dermoscopy, of confocal, of OCT. So we have seen a lot of techniques, and they are improving each year, the same as ultrasound. So I think we in the future we will have much more options.
Wow, that was very well, you know, just put. I do find it very strange that you got that as a response from was that from a journal? They said they
Absolutely, yeah, they
wow.
told me that. And I remember I sent the same article to another journal, and the article was rejected in 15 minutes. I get the response. They
That
said
they
they were not interested. They just were not interested. You know those prototypes answers that the journals give you that says that we cannot give you priority because we are. But I don't know who is reviewing this. You know, they just look the abstract and they say, ah, we don't have reviewers, or we think. I remember when we published, before we published the ultra high frequency anatomy of the skin, where we describe the anatomy of the, for example, the sebaceous glands, the hair tracts, the erector pili muscles. We sent the manuscript to a radiology journal, and this article was very important because it has the correlation between ultrasound and histology. And the journal said that this article was not something interesting for radiologists. So what is interesting for radiologists?
Wow.
That this imaging. So this is the criteria of some of the editors, and that is subjective because you can have an editor with, let's say, a long view, not a short side view, and that give you opportunity, because otherwise they're prejudice and they're I don't know. Everybody who publish suffers have similar stories about this.
But to me, I just find that response to be very like just callous. Oh, I can't. Oh, it's only what I see. Like I don't believe in radio dermatology. I need to be able to see the what the histological features of the tissue. The imaging, at least from what I've seen in your studies, it's very novel. It's very important. I don't see why it wasn't at least given the time or anything initially. Why you would have gotten those sort of those messages. That's very disheartening. Just hearing that makes me think, where else is this going on in the field where people aren't really getting a fair shot of their papers being reviewed. That's very odd behavior.
Yeah, but that is something that happened. We don't know who the reviewers are. We don't know who the. Sometimes you have the letter of an editor that you don't know how much knowledge does he or she has about the topic, despite they are in a, let's say, in a area that could be related to your topic. So we don't know it, but it's improving, I would say. It's better now.
I only hope. But in any case, we are at the end. I want to thank you so much for coming on to this podcast. A lot of my viewers, they were really curious about ultrasonography, especially when it comes to different layers of the skin, different pathologies, dermatological pathologies, especially when it comes to the hair follicles. And we've all been reading your papers, and we really want to thank you for the work that you've done. It's very very well appreciated, and we do think that it has applications definitely in the clinical trial arena. Thank you so much.
No, thank you so much for the invitation. And I hope that your audience could be interested in this field more and more. Thank you so much.
Most definitely. Also, you mentioned you have an Instagram and Twitter. What is the Instagram and Twitter? I'll be sure to. Yeah.
Ax, it's at XWORTS. That's my Twitter and my Instagram. And then I can send you later the the user names, and also the web page about skin ultrasound. So
Most
you
definitely.
can see the courses there. I mean, the information, the articles, because I add a lot of data there.
Most definitely. I'll be including all of that in the link section or the description section of the YouTube video.
Thank you
So,
so much.
thank you so much. Have a nice day.
Have a nice day. Bye.